I'm Rebecca at the Dry Eye Foundation, and with me is Aidan, our Executive Director, and three very special guests for today's session about navigating the world of dry eye prescription drugs. Couple of quick housekeeping items. Aidan's going to be managing the chat and sharing some links relative to our topic today. We are anticipating lots of questions, and we can't guarantee that they will all get answered, but we'll do our best. Anything that we don't get to, we'll be posting in the Dry Eye Talk community forum on the Dry Eye Foundation website afterwards. And one last thing before we start, a big shout out to Petris for their financial support for this project. Our project included building some new patient resources, which we'll be sharing today, and then arranging the webinar. Petris has partnered with us for a few years now, and I've really come to appreciate their commitment to support work that puts real life patient needs in the spotlight. And this project was actually inspired by some kind of heart-to-heart conversations Aidan and I had with people on their team a year or two ago. So way to go, Petris. Now for our guests, we have Dr. Kaleb Abbott, an optometrist at the University of Colorado, Dr. Joseph Allen, an optometrist and founder of the popular Dr. Eye Health YouTube channel, and Dr. Laura Periman, also known as Dry Eye Master, who is an ophthalmologist and a neighbor of ours, relatively speaking here. I would love if each of you could take a minute or so to introduce yourselves and share a little about your personal connection to the dry eye world. Dr. Abbott, would you like to go first?
Sure. Yes, my name is Kaleb Abbott. I'm an optometrist and assistant professor at the University of Colorado School of Medicine. I practice in our dry eye clinic and our Center for Ocular Inflammation. About 2/3 of my job is being in patient care, just seeing dry eye patients, neuropathic pain patients pretty much all day, every day. And then about 1/3 of my job is doing research. So our team of dry eye clinicians and epidemiologists and ophthalmologists and corneal specialists, we do a lot of research pertaining to systematic reviews, trying to kind of better understand what the literature says about the treatment and diagnosis of dry eye. We do a lot of research trying to better understand pain perception. I would say that that is my area of clinical interest, why we can have one eye that looks like this with these dry eye signs, another eye that looks like this, and they might look identical, but this patient has severe symptoms and this patient has no symptoms. So this is really our main area of clinical interest, and we're trying to do a lot of research projects to better understand that.
Awesome. Thank you and welcome. Dr. Periman?
Hi, everybody. Laura Periman, Seattle, Washington. I grew up in the wilds of Montana, raised by wolves, and there's truth in all teasing. But I knew by the time I was 12, I wanted to be a doctor. And fun fact, I can tell you the eye color of anyone I've ever met. It's kind of a weird idiot savant thing, but here we are. And my background is molecular immunology, and I worked on Enbrel before it went through the FDA approval process. And that was prior to medical school. So the idea of modulating inflammation with elegance and precision with biologics rather than steroids is something that's been in my mind for a very long time. So that's a natural segue to my interest in ocular surface disease. And that's why we created the Periman Eye Institute. We are dedicated to ocular surface disease. We do clinical research, phase 2, 3, and 4 clinical research, write a lot of articles. I've had the pleasure of working with incredible colleagues across the space, Kaleb Abbott, Dr. Joseph Allen, brilliant minds, incredibly collaborative. And that's good news because the more we put our heads together, the more we can create meaningful impacts for our wonderful dry eye disease patients. On a personal note, I also suffer from dry eye disease. I have since I was in my 20s, probably from outdoor skiing too much in Montana. But yeah, I do suffer from dry eye disease. I've tried just about everything, and I don't ask my patients to try anything I wouldn't be willing to do myself.
Awesome. Welcome, Dr. Periman. Dr. Allen?
Yes. So Dr. Joseph Allen, I now live and practice in Richmond, Virginia. I sort of got into dry eye because, well, one, I had dry eye issues since I was in my teenage years, and it was mostly just due to contact lens wear and all the hours I would spend in front of computer screens playing video games, watching movies, all sorts of different things. And then, I went through optometry school, did my residency at the VA Medical Center back in Minneapolis. And in the VA setting, all my patients had some form or complications related to dry eye, whether it be because of medications, because of injury, because of aging changes, because of poor health for many different reasons. But there was very limited of what I could do for them. Certainly not even much for medications that I was able to prescribe because of the way the formulary worked at that VA hospital. So once I got out of the VA and started seeing patients, just the general population, I started to kind of turn my angle to be like, I have to better understand what's going on and what I can do about it to help my patients. And I also happened to be employed at a clinic that had built a dry eye practice for like 15 years. And the doctors who had owned the practice were amazing mentors for me and sort of took me under their wing and taught me all of this knowledge. And then I continued to try to better understand it myself, as well as treat my own dry eye. And so that's kind of how I got into it. And so I also, of course, have been very educated or I should say motivated to share eye care knowledge online and try to help educate people. So that's why I've spent so much time building the Dr. Eye Health YouTube channel and being active on social media and trying to share education and knowledge about the eyes, vision, and a big part of that is dry eye. So again, really honored to be here and be alongside Dr. Periman. She's like a mentor to me from a distance. To spend some time with Kaleb Abbott. He's been killing it in the eye care space. I learn from him. He has lectures all the time too. So it's amazing to be here. So thank you.
All right. It is just such a privilege to have the three of you with us tonight. So, doctors, the landscape of prescription medications for dry eye disease has changed dramatically in the last 10 years, right? We went from having one drug to having 8 and maybe a 9th next month, right? Lots of options ought to be a really good thing, and it is. But at the same time, we are hearing an awful lot from the community about the challenges people are facing when they've been prescribed one of these drugs and are trying to figure out, will it work for them? To the point where we were motivated to build some new resources and just see what all we can offer. I'm going to show a few slides here just as a bird's eye view of the hurdles that we're seeing patients facing on the dry eye prescription drug journey. Bear with me a sec. I'm going to share my screen. All right, so here's the easy part. Oops, sorry. Slippery slides here. My eye doctor prescribes a drug, but I have lots of questions, and I may or may not figure out how to ask them during the appointment, and there may or may not be time. So what happens next? I head to the pharmacy to pick up my prescription, and I might face my first major hurdle, which is sticker shock. They may tell me it's going to be $79 or $200 or $864. These are all real scenarios. I don't know why it's so expensive. And apparently it's up to me to figure out whether there's any solution to that, whether I will be able to get some better coverage for it. For many people in our community, this may actually be the first time that they've had to deal with serious problems getting insurance to pay for a drug. So some of us have experience navigating this, some of us have none at all. Next, sorry, like I said, slippery slide, stay there. Suppose my insurance ultimately covers enough of the cost. I still may not be convinced that I should fill my prescription or start using it. I've got these doubts and concerns. Is it going to help? Is it going to cause me all the side effects that I've read about on Facebook? Am I going to have to be on it forever? Lots of question marks. Suppose I do fill it, but maybe I'm still not quite sure, what am I doing here? How long am I going to be taking this? What will it be like? How will I know if it's working? What if my doctor and I disagree? Because honestly, dry eye patients and their doctors do often disagree about the severity of the condition. Suppose I get past that and I start taking the drug, and a few days later, a few weeks later, I've got some new questions and concerns. Maybe I'm getting some side effects. And again, maybe they're different than what I was expecting. I'm not quite sure what it means. Or I'm just running into practical complexities. So I'm taking another dry eye drug and autologous serum tears and my glaucoma med all multiple times a day, and my artificial tears and my usual morning and evening routines. And oh my God, this is starting to feel like a part-time job. I don't know how to arrange my schedule to be able to take all of these medications. So if we get through all of that, then I've got the routine down. But you know what? I just don't really know. Is this working? Is it helping? I think so, but it's hard to tell. Is it this new drug or is it something else in my routine? Do I go on? On the other hand, I'm kind of afraid to stop. I mean, I was going downhill for a while before I started this, and now I seem to be level, so maybe it's maintaining me, but I'm just confused. So this is a flavor. I'm sure none of this is new to you. This is a flavor of what Aidan and I are encountering at the foundation on a daily basis, right? So my first question to all of you is, what are you seeing as clinicians of these things? What resonates most for you? Dr. Periman, you want to jump in?
I'll start. I don't blame patients one bit. This is it's a very confusing landscape. It's very difficult and challenging for throughput. And to your point, what are those typical barriers? Cost, complicated treatment regimens, side effects, and belief that it works. So doctors and patients share those same concerns, and that's before we even get to the insurance company obstacles and their shenaniganery. So yes, I'm very sympathetic to this patient's part of the journey, and that's why I'm so glad you're having this discussion. I hope it's a wonderful service to patients who are having these questions. Very legitimate.
Yeah, I was gonna say every single thing that was mentioned is a challenge that, like, every single day that we're running into these challenges. Today, I had a patient that had to send me a message because his medication, it's not going through to the pharmacy because it's kind of stuck in this. So from my perspective, I write a prescription for my patient who has some significant level of dry eye disease, and that prescription, it says, hey, they need a prior authorization before I can even prescribe it. So the insurance has to somehow dictate whether or not the patient would qualify for that medication. And then I have to not only send my records, but then explain in detail that they've tried 3 different artificial tears and for how long they've tried it, and that they've failed those, or that they've tried some other medications and did they have side effects to those medications. And then even through that process, they still that gets stuck in this kind of work zone where multiple people are looking at it. Possibly AI is looking at it now. My patient's basically sending me a message saying, I still don't have this medication, because I gave them, thankfully I was able to supply them with trials from the office, but that may only last 10 days. And so they're getting as frustrated as we are, because we're kind of like, we've done everything that we can, and now we're just waiting for like some sort of approval from the insurance company. So I know getting things covered and paid is sometimes just as frustrating for us, because we want our patients to get better. We want them to feel better. And then I don't know how you guys all feel when you prescribe something and you're like hoping, you're like fingers are crossed, and your patient's coming back in a month or 6 weeks or whenever, and then you're like, please let them be better. Like, please let them be better. You're like, you want to see some improvement. I was stuck in that several times today. I'm just like, oh God, I'm just hoping. But yeah, I'd love to hear from you, Kaleb. What are you thinking?
Yeah, I think from our end, on the eye care practitioner side, we do a lot of work to try to understand what's driving the patient's signs and the patient's symptoms. We do certain testing to try to figure out what's really going on. Our understanding of dry eye has evolved quite a bit, in the last, 2 decades or so. We're starting to mechanistically understand it better, understand what's driving symptoms better. And the dry market is so crowded now. We have all these different options, which is amazing because we can target specific portions of the inflammatory pathway, the dry eye pathway, evaporative dry eye, associated blepharitis or MGD. And so it's nice that we have all these options for patients, but then we do all these tests to figure out what's going on. Then we come up with, in our mind, what we think the best treatment is. We prescribe it for patients, and then patients can't get that. What we know is best as doctors. And I would say one thing is if, with the very first thing that came up, which was sticker shock, with price, if the price is really expensive, we don't necessarily know that it's going to be really expensive. So reach out to your eye doctor's office and let us know. I can't tell you how many times I have a patient that comes back and they'll be using a medication that I assume is going to be relatively affordable. They come back for their follow-up and they say, my eyes are feeling better, but I really can't afford paying $600 a month for this. And I say, you're paying $600 a month for this. And I said, if you're facing that much of a expensive medication or sticker shock, it's very helpful for us if you reach back out to our office and let us know, because sometimes it's as simple as insurance wants us to start with a different medication, and we know that medication sometimes works along a similar pathway, so we can try that. But communicating back to your eye care provider can be really, really helpful in cases like that, because our goal in the end is to control your symptoms the best that we can at the lowest cost to you as a patient. And so, but sometimes it's hard for us to predict, what your price is going to be.
Yeah.
So pricing and insurance, let's dig in there maybe a little bit more.
Yes.
And yeah, I know you've got opinions on this. It is quite something out there what's going on. I gotta say, to put together our webpage on this, I had to go through so much education. I mean, I'm 56 and I've been insured for an awfully long time, but I never knew any of this stuff that is all these different factors that are factoring into what people are paying for these dry eye drugs. And, big picture, one of our biggest challenges is they're all new, right? I mean, there's only one that has any generic. So insurance companies are trying to find any way they can to essentially not pay for these. On the site, which I think Aiden has shared in the chat, and I'll be running through it a little bit later on, we do break this down. All the different pieces you can learn that may help navigate this. But I'd love to hear from the doctors, maybe a little bit more about who's my problem solver? I mean, I love, Dr. Abbott, that you're saying reach out to us if it's that expensive. We don't intend that. We don't want that. Let us know. But I think a lot of us, we don't want to make our doctors spend all this time on this either. Who can help us navigate the insurance issues? Anybody want to speak to that?
I'll take a first crack at that. So there were several little hints into my perception of the problems in what Dr. Abbott and what Dr. Allen just said. The game is rigged. It's non-transparent, and that works to everyone's disadvantage. The only advantage it works to is to the health insurance companies, right? They want to keep it all in smoke and mirrors of what they'll cover, what they'll pay for, what they've got on tier 1, 2, 3, 4. That's not always in our EMR. So your doctor looks at the situation and says, I think this medication is ideal for this patient. They've already made that clinical assessment, clinical judgment, made their best clinical decision on what that prescription will be. And then insurance companies come along and second guess us. Prior authorization, really? Back when I trained, and I'm about to date myself, we didn't have prior authorizations. This is a new thing over the last 15, 20 years, and it's designed to deny, deflect, delay care.
Okay, can you give us the 6th grader education? What's a prior authorization?
So prior authorization is a request from the health insurance carrier to justify the prescription that you've sent in after you've done the evaluation and the treatment of the patient. Basically, they're trying to check your homework as if they went to medical school and optometry school and know better than we do. So it's essentially a false, arbitrary, and capricious barrier to prescription drug access for patients. So it's a made up thing that used to start like 15, 20 years ago. It was for really high ticket items, such as MRIs. Back in the day, they were very, very expensive. But there's been this mission creep. It's like, oh, look at all the money we're saving with prior authorizations of putting up these obstacles that now have been abused to the point that even a simple steroid can be met with an obstacle of a prior authorization. I had that happen to me, gosh, about 3 or 4 weeks ago. A patient with Sjogren's, bad ocular surface disease, can't tolerate BAK. So I wrote for Lotemax ointment, right? Because it's preservative free, BAK free. That's the one steroid that they can tolerate. Well, we got denied. We did a prior authorization, got denied, submitted an appeal, and in their appeal letter was all the things that we addressed in our, or in their denial. It was everything that we had addressed in our appeal letter. Well, that made me pretty mad. So I went to LinkedIn and I complained about it. I called out the company. I said, this is a simple steroid. I have my reasons and you're second guessing. And if you had bothered to read our appeal letter, you'll see that we addressed everything that you wanted. We did all your step edits and this patient still needs it and deserves it. And you're practicing medicine without a license. I wasn't intending for this to happen, but over 100 comments, over 100 shares on LinkedIn, and take a wild guess at how many impressions that post got. Take a wild guess, Rebecca.
100,000? I don't know.
200,000 impressions. I hit a nerve, and it was just me being
Yeah.
like, Mama Bear, like, my patient needs this. How dare you create this arbitrary and capricious obstacle? So it's a huge problem for doctors as well as for patients.
And I'd love that you're fighting for the patient's need on this. One of the situations that I feel like people in our community are experiencing is they don't necessarily know any of this stuff going on behind the scenes. All they know is
Right.
the pharmacist said, that'll be $900, please. Right?
Pharmacists love to throw us under the bus. Well, your doctor hasn't submitted a prior authorization. Oh, you mean this one that you acknowledge receipt of? They'd love to throw us under the bus all the time. Your doctor's really trying to help. The game is stacked against everyone, and they are very happy to let us pit against each other and walk away with all the money.
I think another confusing aspect, from our side of things is that every insurance company has different drugs that they prefer. And so we're in our minds trying to memorize, oh, this insurance company wants this drug, then this drug, then this drug. That's their order of things, but this insurance company prefers this other drug first. And so we're stuck trying to memorize, what's on formularies and what is preferred, to try to save patients time, trying to save us time too, because if we write the prescription that is not preferred by that insurance company, then it delays the patient getting the medication by several weeks as we're trying to fight this, and we figure out, oh, the patient, the insurance company wants us to have actually prescribed this. And so we tried to memorize it, but there's a lot of insurance companies out there.
And it can change at any time, right?
Yeah.
What was a preferred
Yes.
behavior is no longer preferred, and the price gets totally out of attainment for a lot of people.
Mm-hmm.
I know. I'll add that a lot of the newer medications that are coming out, a lot of the companies that are making these medications are recognizing there is this barrier for both doctors and for patients, and so they are trying to create these options where if there isn't an affordable option or there isn't good coverage, then there is this kind of cash pay option, which sounds kind of backwards because you'd think, hey, the pharmacist is quoting me this price. Well, the price that they're often quoting you is what your insurance is kind of dictating. So they're offering now, there's some sort, not every medication offers this, but some of the newer ones do have this option where if you say, hey, I can't afford that, then you can just say, hey, I'll pay cash. And there may be a guaranteed price of like $75, as an example. I don't know, everybody's is different and it changes depending on where you live, and there's a lot of variables, but that might be more affordable than, the $900 price. And so it is worthwhile, if you're stuck in this limbo zone of like, I just want this medication, to first call the eye clinic. A lot of our clinics, I can't say this about everybody because I know Dr. Abbott, you work in more of like a institution university setting, right?
Hospital, yes.
Yeah, a hospital setting. Dr. Periman, she's got her own private practice where she's paying staff members to take care of phone calls and things like that. And thankfully at the clinic I'm at, we have like a staff member who's dedicated to just managing prior authorizations and all the medications. And that's at least worthwhile to call the clinic if you can, just to be like, hey, did my prior auth go through? And that's at least one way to check on it, because sometimes it maybe gets stuck somewhere, maybe on my end. Like I thought I hit the submit button, but it didn't get through. So that's been a reminder. But then perhaps there's a spot where it's like, you know what if we just send it without the insurance prior auth? And then there's this additional option you can mention to the pharmacist, I can't pay that. Is there another option? And that might be a way to be like, hey, at least get it in your hands for now while we're waiting for the prior auth to finally click through.
So that's just the cash pay option that that Dr. Allen is mentioning. Sometimes that has to go to a certain pharmacy, though. So one of the top questions we get asked, from our patients is, so I'll say we can prescribe this medication, but it has to go to this specialty pharmacy. And we explain why, but then a lot of times we get callbacks from patients, saying, I don't want to have it sent to a specialty pharmacy. I want it to go to my local pharmacy. It's right down the street. And then they wonder, why in the world do we keep having to send these medications to these specialty pharmacies? So that's a constant source of frustration for patients. But and maybe some of the other panelists can speak to why we have to do that. But a lot of these specialty pharmacies, they have agreements with the pharmaceutical company that they are going to be the preferred pharmacy for a certain drug. And that is the only pharmacy that can offer certain pricing, discounted pricing, cash pay plans, and things like that. So if we send it to a local pharmacy, it actually drives up the price substantially.
Yeah, and we'll walk through a little later on just kind of some of the material we've got on our site, walking through people through the funnel of, okay, here's how much my insurance is going to pay in a best case scenario. But then here's also some manufacturer support things, just as you've been sharing, that we can potentially tap into, and then anything beyond that. So let's shift gears now from insurance and talk about some of the things that may cause somebody to just kind of pause or hesitate before starting a drug. Let's talk about risks and side effects, because I think this is very much on many patients' minds before they get started. So my question to you is, how big of an issue is this, do you feel, among your patients, and how do you steer patients through these questions?
Sample dosing in the chair is a great way to level set on expectations of the drop sensation and starting that education piece on side effect profiles and what's tolerable and what isn't. So I really appreciate in-office samples for chair dosing to give patients some insight into that side effect profile. And then if we can discuss if it's manageable or not, before we even do battle with the stupid insurance companies trying to get the drug through the prior authorization juggernaut.
I understand patients' hesitancy, to take some of these drugs. When you read the package insert, some of these side effects sound scary, and you're reading through all of them. And you're saying, "Oh my gosh, like this sounds worse than the dry eye symptoms that I'm experiencing right now. Do I want to take the risk?" I guess one thing to note is that all of these drugs have to be studied. They have to go through a safety study. Usually, that safety study is a 365-day safety study, to make sure that there's no serious adverse effects associated with the drugs. So they have to undergo lots and lots of testing. Another thing to keep in mind, is that when a drug first comes out, there's a certain side effects are listed. Those are the most common side effects that were found during the FDA clinical trials. But as the drug has been out, sometimes providers reach out to the company or reach out to the FDA and say, hey, I'm having patients experience this side effect. Sometimes patients directly reach out to the FDA or reach out to the company and say, hey, I'm having side effects of this. The pharmaceutical companies are required by law that if a side effect is reported to them, they have to report it to the FDA. If it's reported a certain number of times, that also gets added to the package insert. So when you see these kind of laundry lists of tons of side effects, that might have not been there originally whenever the drug came out, but then they might have been added later on just because things have been reported to the FDA. It doesn't necessarily guarantee that that is a side effect of the medication. It was just something. It was something that the patient experienced when they were taking the drug. So, but it's not proving that it is due to the drug.
Yeah, and I'll just add that I think it makes sense if you've been prescribed a medication and you're like, okay, I need to invest into this, right? Whether you have to pay a deductible to insurance or you're paying out of pocket, and then you put it in the eyes and you want it to just feel good and take all the sensation away. But a lot of them, more often than not, do cause some feeling of discomfort. There's a little bit of a stinging, an irritation. The eyes become red for a few moments. And then even some of them cause what? Your vision can fluctuate or go blurry for a few moments. There's some that cause a bad taste. If you're using one of the nasal spray, you may end up coughing or sneezing a whole bunch. So I think it's definitely on us as doctors to mention, hey, this may happen, or like Dr. Periman just mentioned, putting a drop in the clinic. That would be a fantastic option. I wish more doctors would do that. Even myself, just to get patients to kind of be like, hey, this is what you're going to expect, so this is normal. But I know even before we jumped on the webinar, we were just discussing that sometimes you get a medication and maybe you won't have side effects, but then 3 months later, you get switched to a generic or a different manufacturer of the same medication, and all of a sudden you're getting symptoms. So I think it's important, just as the other doctors have mentioned, that it's good to know what potential side effects there are, but stay in conversation with your doctor if you're having something new, if something did come up. And then just also be open-minded, because I've had patients who start a medication and they use it for a few weeks and all of a sudden they get like the flu. And they think that they got that from the medication. And it's like, well, no, it was probably just you had the flu and you just happened to be using the medication at the same time. So also just, again, it's important to have that conversation with your doctor so that they can kind of coach you through what's normal, what's not, and if they need to report something.
And all patients are different. Some of the most common side effects with some of these medications, other patients don't experience that at all. In fact, they experience different things. That's kind of one difficult thing in our field is pain perception, why people experience the side effects that they do experience, why some patients experience relief with certain drugs, other patients, experience more relief with a different drug. And so sometimes it takes a little bit of time to figure out how tolerable a drug is for each individual patient, then also to figure out what drugs work best for certain patients too.
I would say from my own experience too, how I experience a drop today is not necessarily how I experience it tomorrow or a month from now. It really is can be all over the place, just depending how my eyes are. Also, time of day too. I love that idea of being able to actually have it go in the first time in the office. I've actually never heard of anybody doing that. So that was super interesting. I wonder, does anybody want to maybe tackle what's the threshold? Where do you draw the line between side effect and potential safety concern, or somebody's got an actual issue where they need to discontinue? It's one thing to have something that is uncomfortable or inconvenient. It's another thing, I think I'm having a reaction. Can anybody speak to that?
I think true allergic reactions to the medications are uncommon, like really, really, really uncommon. True allergic reactions is redness, stinging, burning, blur, those sorts of things. Those are common side effects and that people may misattribute as being an actual allergy, and it's actually not. So that's a great conversation with your doc. It's like, hey, I'm having this response and I'm noticing these things. Do I have an allergy developing? And talk to your doctor about it. The chances are no, but that's a great conversation. Maybe there's an alternative that you tolerate better.
Yeah,
So-
I was gonna say, I know I had a patient where I had to put on a medication just for a short term, and they had a abnormal reaction where the eyelid swelled up, and they came in thankfully within just a day or two later. They're like, I don't think this is right, and I was like, no, I don't either. But we had to have that conversation. Do we want to, because it looked fine, it wasn't going to be an emergency, but we had that discussion. Do we want to keep trying it, or do they just want to put, wave the white flag and let's get them off of it, let's rinse out the eye and switch to a different alternative? And that's ultimately what we did. But again, they did the right thing. They called us, we checked on it, and then we went through the process of actually reporting it, just like Dr. Abbott was saying.
So I think when we're prescribing dry medications, most of the time when we're talking about unpleasant sensations or things that patients are experiencing, we would say that that's a side effect: the burning, the stinging, sometimes redness, things like that. Then we have, separately from side effect, is adverse event, where something kind of harmful or something bad really happened from it. And then we have serious adverse effects. And it's common for these drugs to cause side effects. It's rare to see a adverse event. It's exceedingly rare to see a serious adverse effect. So, when we're talking about risks, I guess, of using these dry medications, we don't generally see anything like vision loss or anything that is, permanently affecting vision or permanently causing damage to the eye. We're generally talking about something that's transient, that when you stop the medication, it will, the problem would eventually go away.
Yes. When we rank side effects in clinical research studies, we rank it adverse event, mild or severe, and the event, is it related to the study drug, likely or not, and what the nature of it is. So, for example, Sequoia has a UTI on the side effect profile, and I'm like, it's an eye drop. That's where it goes, in the eye. Like, I don't know what happened there, but when you do these clinical research studies, you have to report everything that happens during the course of the study, whether it's related to the medication or not. So when you see those extensive, scary package insert lists, know that they're listening for everything in the course of those clinical trials and the safety studies and all those sorts of things. And I really appreciate this discussion on the spectrum of patient side effects that they can experience. And, hopefully we can help, lower some of the anxiety that can happen around some of those.
Anxiety is the word, isn't it?
Yes,
I mean, anxiety
it is.
characterizes everything in the entire dry eye world.
Yeah, it is.
I feel like one of the interesting trends I've noted out there in recent years is based on the accumulation of experiences reported in social media groups from drugs. I think some people get the impression that drug X always causes this side effect. This one burns, this one tastes bad, this one is, but the reality is none of these do that to everyone.
Correct.
I mean, I hear from plenty of people who've been on drug X for forever and they don't have those. Can you speak to that at all? How do you talk to the kind of expectations point? Do you have patients walking in saying, oh, but no, I don't want that one because I know it is going to do this?
Well, you can explain it really quickly with, how do you feel about cilantro? Do you love it or you hate it? Not everybody's the same. Right? So that's the quick and dirty answer. We all have different receptors, different tolerability profiles, pain, thresholds, all these sorts of things. So you're right. Like, there's no such thing as always or never in medicine.
You don't know what side effects you're going to experience until you try it. Sometimes if a patient's hesitant, I've had patients hesitant to try a medication due to side effects. They try it and they happen to be a super responder to that medication, meaning that the drug worked super well for them and it relieved so many of their symptoms and they were so happy. But they wouldn't have known that unless they would have tried it.
I love it that you brought up the super responder idea. Like, what if it turns out awesome?
Mm-hmm.
Right? What if?
I'll tell you that is not a possibility on a lot of our horizons a lot of the time. What if something actually could work really well? I mean, I hate to sound pessimistic, but I feel like the vibe in our community is often, oh my God, I've tried so many things and nothing works, right? But the idea that something might work really well, I think we need to hear those stories. We need to know about that happening.
Mhm.
I also
Yeah, I
just
mean,
think
there's. Oh, sorry, Joe.
oh, I was just
Keep
gonna
going.
say, I was just gonna comment that I think a challenge because you can try one or two. We used to only have one or two medications for it. Now we have like 8 plus more, if you include all the other treatments that we have. But I just like to remind people, especially if anyone's watching and you're like, I've tried so many things, why is nothing working? And that's because there's no one silver bullet that's going to work for everybody's type of dry eye. And I know Dr. Abbott and we've kind of talked before about like maybe dry eye is a poor term because there's so many drivers, there's so many possibility things causing a different person's dry eye, and maybe multiple medications or multiple treatments need to be tried even simultaneously or chipped away one by one till we finally get some relief of symptoms. So I just wanted to add that.
Yeah.
Sometimes it's about trying to find the perfect combination for patients. So sometimes, it's trying to figure out, you need to be on this medication together, combined with this procedure. That is the secret sauce that works well for that patient. And every patient's totally different. So when it comes to a patient's dry eye journey, it takes, sometimes a lot of visits to figure out exactly what works well. And there's a lot of nuances to try to, pivot away from this and try this instead. And so it does take time, but I'd say in general, if you give your doctor time and you're willing to try these different medications, then we can provide relief. And it's so rewarding when we figure out that combination that works for a patient.
So oh, go ahead, Dr. Periman.
I was going to say, I love that. It was so beautifully expressed.
So we're gravitating into the whole efficacy topic, right? That's the big one for us patients. What works and how do I know? And I think something you mentioned, Dr. Allen, about whether dry eye is even the right term for this, that's absolutely been my song sheet for a long time. We look at it at the foundation as ocular surface disease and getting really specific about that, and ocular surface pain, which is the patient world. We're uncomfortable, we hurt, we're thinking about our eyes all the time. I think that a big part of our struggle with figuring out when something is working is everybody's using different yardsticks, right? What's the measure of success? We patients are gonna struggle a lot with whether something is working or not. Yardsticks, who would like to speak to that? That's a really broad question, I know, but it's like, how do you,
How do we know if it's working?
yeah, how do you have that? What do I expect as a patient? How will I know when it's working? And maybe you have a different measure because you're looking at clinical measures. My measure is, do I feel better? How do you navigate those conversations with patients, and how do you reconcile those two worlds, signs, symptoms?
So we just did a study where we were sending out surveys to a lot of dry eye providers, and we're trying to understand how dry eye providers view success. Do we view success more when we improve corneal staining or improve tear breakup time or improve meibomian gland dysfunction? Or do we view success more when we improve patient symptoms? And there is great agreement actually between optometry and ophthalmology in this, that dry eye providers, we want to see patients feel better, that is our number one goal, that is our number one indicator of success with the treatment. Sure, seeing corneal staining improve is great. Sure, seeing certain other dry eye metrics and tear breakup time improve is great. But in the end, I think the best indicator is whether or not we're improving patient symptoms, if patients aren't having to think about their eyes as much as the day goes on.
And sometimes that can be subtle, right? So one of my favorite things is, validated questionnaires. Human beings forget pain, otherwise you would never give birth more than one time, right? It's baked into our brain physiology. So validated questions are one way, but also like a key daily task that they had trouble with. For example, wearing contact lenses not more than 2 hours. Well, how long are you wearing them now? It's like, oh, I'm up to 6 to 8. Okay, well, that's a meaningful change, right? Or how long can you use the computer? It's like, oh, they don't start bugging me till more like 3 o'clock, and it used to be like 11 or 12. So like those little gains, celebrate those, build on those, look for those incremental daily activities of daily living, tasks and improvements in your life. Those matter, and they create enough positive momentum that your doctor can help you build on those to create even better effects.
I love setting
We didn't get here
practical
overnight.
goals.
We can't fix it overnight, right?
It's like the word better, pretty vague. I don't know what my goalpost is,
Yeah.
but to be able to work on my computer for 4 hours straight without thinking about my eyes, that's a little more concrete. Knowing that I can do that, I know that I have made progress.
Yep.
Or being able to drive a longer distance. There's people that are constrained in their driving because of dry eye symptoms. I love
So
those.
I had a patient today that we were doing IPL, and I was asking her for hours for feeling better. And she's like, I don't really, I don't know. They seem to feel the same to me. I went back to her original exam the first day I saw her. And I said, so I always type in primary symptoms, secondary symptoms, time of day, what's bothering the patient the most. And I said, okay, well, when we first saw you, you were reporting that you had a lot of redness, you're reporting burniness, grittiness, fluctuating vision, that you're thinking about your eyes constantly throughout the day. So we kind of went one by one through the symptoms. And she said, oh, yeah, that's better. That's better. That's better. That's better. But for patients, it's hard because you're suffering from this all day, every day. And so this is your normal. It's hard to think back 3 months ago, and sometimes realize, if you've improved or not improved. And that's why, as Laura was saying, the validated surveys, the questionnaires are really helpful because we can actually quantify your symptoms via an actual score. And then we can say your speed score was 21. Now it's 13. It's gone down so much. So, symptom wise, you are doing better.
And we're starting to incorporate subjective questionnaires like this in our clinical research in phase 2, 3, and 4 clinical research. They're called visual analog scores, VAS, and it's literally a scale of 0 to 100, and the patient marks how wide your dry eyes feel. They take a pen and they mark it. You literally pull out your ruler and you measure in centimeters how much it is, like 74. Wow, that's high dryness score. Now you're at 28. That's significant reductions, clinically significant reductions. So you're going to see more and more of the medications coming out include those patient perspective symptom relief metrics as well, which is good news.
Yeah. And I just like to share kind of the analogy of how progression or improvement often goes, because it's kind of like if you've ever tried to improve your fitness, or whether you're lifting weights to try to add muscle or you're trying to lose weight, right? They take before and after photos, but you go through this process for 3 to 6 months and you don't feel like your body's changed because it's changing by like 1% every single day. And it's such a small amount, you don't realize it until you look at your before and after. And then you're like, whoa, it's a lot. I've come a long ways. I didn't realize where I was before. I almost wish we had like true before and after like photos of what the surface of the eye looked like, right? A mock image of what visual acuity or what clarity of vision would look like, kind of like how we have with some of the cataract measurement instruments. I feel like that would be a really great thing to have, even from a patient perspective, right? Maybe we'll have to come up with a standardized way to do that.
I love that. And I love that you brought up the weightlifting analogy. Like you're going to the gym, you're doing the work, you're not seeing the day-to-day change. But a key part of that is making sure you have enough protein intake every day and you're getting enough rest and recovery from the workout. I struggle to get enough protein in. It's like my least favorite food group. Like that's what I know I've got to do it in order to get the gains that I need from 1 month to the next.
So this brings up the question of how long is a fair trial?
depends on the severity and the diagnosis and what else has been tried, right? If you're coming at this, you know, on the 90-yard line or the 10-yard line to get to your touchdown of dry symptom relief, that matters. So it's different for everyone.
Anybody else want to weigh in?
Yes, what Laura said is definitely correct. Insurance companies sometimes view it differently. Insurance companies say you need to trial this for 90 days. So if a patient tries it for 87 days and says it's not working, insurance company says, nope, you didn't do that 90-day trial. You got to start again and do 90 days before we know. But yeah, patients respond at different rates. Sometimes patients respond really quickly to medications, and you're amazed, and they notice almost immediate relief. Sometimes patients have to use the same medication for more than 3 months, and it continues to get a little bit better each month and each month and each month. And just when you thought it, you kind of plateaued, see the patient 3 months later, and they say, no, it's actually gotten even better since then. So some of these drugs can actually continue to improve symptoms, up until the 1 year mark.
I love that you brought it up that way, because when we do the clinical research on these, we have such a tightly defined patient population. And if you fall outside of that range that was studied in the FDA trials, you might respond faster on this end and you might take longer on that one. And so the insurance company insisting on these arbitrary timelines is yet another rock in my craw, another irritant. It's because we're clinicians, we're doctors. We're seeing the patient in front of us. We are treating them with medicine, not theoretical timelines.
So imagine I'm starting a dry drug for the first time, and I give it however long we've agreed is going to be, maybe my initial trial. If I am not feeling better, are there circumstances under which you would advise me to continue anyway?
Yeah, I'll just chime in that because our perspective as physicians, as doctors, is we need to make sure that this eye is healing and actually in good vital status. Because there's a lot of our patients, I know we see, that maybe don't really complain that their eyes are that terribly dry, or they don't think, oh, it's not too bad. But from our perspective, the surface of the eye is in a really critical spot, and we're like, no, we need to figure what's going on. We need to get this healing, because it's like having an open wound right on your skin, and you may feel like, oh, this isn't that severe, it doesn't really bother me, but to us, we're like, you have an open wound. Like, we need this to heal. So and sometimes the medications, it takes time, but we may be able to see that it's healing. We can be like, hey, it's getting better, even though your symptoms haven't caught up yet. We know we need to get things to repair. And so sometimes I'll have to tell patients that exact thing. I'm like, we need to keep going with this. We'll try some other methods to help with symptoms, but we ultimately are seeing improvement with the tissue. So that's something I think it's just important to understand.
This is really quite common. Oftentimes we see that symptoms lag signs. So once we're healing the ocular surface, so the ocular surface is starting to be restored, but then the patient's symptoms are trailing maybe a few months. And so we can tell the patient, I know you don't feel any better, but everything's looking so much better. I'm confident that if we stick with this regimen, you're going to start to eventually experience symptom relief. Sometimes it takes time for the nerves to calm down too. The nerves have been firing and firing and firing and firing, and we're healing things. And then the nerves finally take a breath and then calm down a little bit, and then the patient experiences relief.
Love it.
As patients, we really do need this kind of support to understand the potential timelines. And it's difficult. There's not a lot of time in today's medical world for lengthy conversations about these things. Does anybody want to speak to that? How do you prioritize getting patients the motivation and the support they need on these drugs when clinic time is so limited? Is it emailing with patients? Do you have a fact sheet that you might provide, or maybe it's about equipping patients with how we can equip patients to ask the right questions?
So one of the things that we do is we slow the appointments way down. A brand new patient spends an hour with me. So that's one way that we mitigate that. It's a lot of information at first because we're casting a very broad net, looking for all of the contributors and co-conspirators to that particular individual's dry eye disease. And it can be overwhelming for some patients, but we invite them to read, recite, review, right? This is how you acquire information. It's like, don't worry about absorbing this all in one go. We'll type everything out in your after visit summary. But every time you come in for your in-office treatments, you're going to have the opportunity to ask questions. And by the end of this, you're going to be well versed on all of these different processes, and your understanding will increase significantly. So you don't have to get it all in the first visit, but you'll be able to revisit and regroup and review the treatments and why over time.
Awesome, thank you. I want to just tack one more thing onto this topic, the whole efficacy picture. Is this working for me? I'd love to hear your take on it, if this is kind of echoing at all what you experience with patients. A lot of us have a lot of different symptoms. Some of those symptoms are more important to us than others. Some of them bother us more than others. But I think the thing we hear from the community is how constantly we're aware of our eyes, right? People sometimes know they're better when it's, I think of it as background noise. It's not that it's gone, but I'm not thinking about it anymore. Does that make any sense to you as kind of a metric for, yes, I'm getting better?
That's the holy grail. You're not supposed to think about
Yes.
your eyes all the time. That's the ultimate goal. Get it back to physiologic settings, original factory settings. You're not supposed to be thinking about your eyes all the time. They're supposed to be doing their job without discomfort, with a stable visual interface. So yeah, that's the goal.
I think figuring out where we can aim on that spectrum that might be short of perfection becomes where some of us fall down. It's like, is this as good as it gets?
Right.
Right.
Well, I know my two colleagues here are both high achieving individuals, and I'm sure they were never content with an A minus. These are all like A plus driven doctors. And so we just don't give up until we get that patient to a stable point.
Yeah, I think one thing that's hard about dry eye, there's no cure for it, and it is a chronic condition for patients. Sometimes when it comes to our dry eye clinic, I feel like we can get you 70% better, 80% better with, this much work. But then that final 20% takes this much work, takes so much more time, effort, money, because, treating dry eye is not cheap from the patient perspective. So, sometimes we end up discussing like, yeah, we can get you 70, 80% better with this. If you want more improvement, sometimes it takes a lot more. And we try to find the happy medium there.
That's a great discussion. Exactly. It's like, we can keep going. It's up to you. Let's talk about what's involved. I love that.
Mhm.
All right, we're going to pause here for a couple minutes while I switch over to doing just a little tour of our new tool on this topic. And then we'll come back and start tackling, I think, I know that you've been answering lots of questions along the way, but we'll tackle some more questions in the discussion part here. So bear with me a second. I'm going to share my screen again. All right, so I just want to show you the new page that we have. If you're starting from the Dry Eye Foundation website, dryfoundation.org, you go up to resources and then Dry Eye Zone, that was our original website from 20 years ago. We still maintain some information on there. And the new tool is linked at the top, but it's also under the drops and drugs menu. And it's My Dry Eye RX. And it starts with, I've been prescribed a dry eye drug, now what? And it walks down through roughly the same topics that we had in the slides I showed at the beginning, these different hurdles that I might be facing. One, my copay is too high, or I'm just being charged an awful lot. And each section will have more information and resources, and in some cases, links. So on the cost, which we know is a big topic for our community, we've got some information resources buried in the accordion here on, you can think of it as like a funnel. Here are all the different things that may be coming into play with the price that the pharmacist just quoted me. And some of that I may be told about, some of it maybe not. I shouldn't just assume, oh my God, that's my copay, I can't afford that, and walk away. There's lots of questions I can ask. There may be things that I can ask for exceptions to. There's requests you can put in. There's appeals that can be made. But first of all, it's just understanding what are the factors that go into it. Then we have, again, kind of a flow, things I can do. My copay is too high. Okay, I can go through that list and find things to address. If it's still too high in a best case scenario, there's some manufacturer support, whether that's copay cards or cash pay prices, or maybe income-based patient assistance programs that are offered by some companies. And we have a link there to a whole other section that's specific to the individual drugs. All else fails, then are we talking about alternative treatments? If I just can't get the one that my doctor's recommending for me, and sometimes exceptional circumstances, I'm really motivated to fight. We do hear from plenty of people who are considering, either they're getting a different plan or they're changing insurers. If they find they have an ongoing need, that may be what makes sense for them. Next, scenario where folks don't have insurance at all. Some ideas and tips there from the generic side. We know that's limited, but at least there are some, again, manufacturer assistance and other options. Then I haven't started my prescription yet because some of these common things we were talking about. Will it help me? Will it hurt me? How long will I be on it? Will I be able to keep paying for it? Lots of information if you drill into these sections. What does a fair trial look like? We got into that in depth here. We've got some suggestions on the site about mostly around how to have these good conversations with your doctor before starting, how to get a plan in place that will set you up for success, where you will feel confident continuing until your next follow-up appointment, and where you can avoid maybe adding things to the mix that will make it impossible to determine what was actually helping. Then we've got I've gotten started and I'm running into a little trouble. People have lots of practical questions. So again, here, tips for what to do and what questions to bring back to your doctor. Then the big one at the end, do I go on? And, to the extent the drugs may be costly for us, that question gets bigger and harder based on what I might be sacrificing even to stay on it. But regardless, there are calls to be made there. And what we've done for that section is just brought together a lot of themes that we see repeating themselves in the community. And they're not do's and don'ts. They're things, patterns to think about and see, does that one match me? Is this one resonating? Am I setting the bar too high or too low? Am I too fearful of starting something? Or am I hanging on to something for too long that, my doctor doesn't even think I necessarily need anymore? Multiple treatments, binary thinking, it works or it doesn't, versus things like we talked about today with how things will evolve over time. So just wisdom for the journey type advice in there. So encourage everyone to just visit this page. Again, it's right up there at the top on the Dry Eye Zone site. So that's our new resource. It's going to evolve and grow. It was, like I said, huge learning process for me, just understanding more about insurance and some of these other topics too. We love feedback, so love to hear from people what other topics you might like us to cover in there, or any kind of input. All right, so our doctor panel now, we would love for you to be fielding some of these questions. I might, Aiden, need your help on this because I can't read the Q&A. Sorry, this is just a little too small for my vision. So could you maybe step in and pick a
Totally.
question? Or if the
Yeah.
doctors want to just leap in, you're welcome to as well.
Hi, everyone. The doctors have been really good about answering questions in the Q&A. So I might just scan and see what has been answered so far that's kind of relevant to the access and the drug conversation. Right. One question from YouTube. How much or how often do you utilize specialty pharmacies that most of these prescriptions work with that helps lower prices for patients? So Dr. Abbott chimed in there. I said most should be familiar with specialty pharmacies. Did you want to talk about that one?
Sure. Yes. So the specialty pharmacies, most of these new medications have to go to these specialty pharmacies, and it's a little overwhelming from the provider's perspective initially trying to memorize all of this. But when you prescribe these drugs every day, you eventually learn which specialty pharmacies need to be used, and it overall benefits the patients to utilize those specialty pharmacies because they get it quicker. The pharmacies have it in stock, and they can get it for the best price.
I'll just even speak as somebody who's used a specialty pharmacy a few weeks ago. Actually, one of the newer dry eye medications that came out, I had one of our other providers write me a prescription for it so I could experience not only the medication, but experience the process of this specialty pharmacy sending me a text message. I had to read the text message, go to the website, confirm the medication. And I was actually quite pleased with the experience because it worked so well. But I know it can also be, I think some of our patients, if they're maybe not as tech savvy with their phone, or they're like, suddenly I got this text message from a number I don't recognize. There's a little bit of a process to it. But I think again, just as Dr. Abbott mentioned, most doctors can learn this, or they can even just go to their website. It's like, oh, it's my first time prescribing this new medication. They can go to the website and they usually say, hey, we are working with this specialty pharmacy. And so it's an easy way to begin the process. But I know from just using it myself, I found it really simple, and the medication was mailed to my house within a few days. And I thought it was really convenient.
Another quick question that I really liked that someone asked on YouTube. What can sales reps do to help make your job easier, your staff's jobs easier? Periman chimed in and she said samples, helping with training on staff on how to clear PA hurdles forced by health insurance companies, patient assistance programs, copay cards, etc.
I like when our reps come in and they've already done kind of the hard work or finding out, hey, where should I send this medication to get the fastest response, or who has like the best customer service. Sometimes they've already done that work for me, so I know exactly where I need to send this medication so we can get it as quickly as possible with as little hurdles, and that's helped me out quite a bit.
Another question, we may be able to answer this and we may not, but as Deidre said in the Q&A, if I've been on a drug for some time and my symptoms have increased after being reasonably smooth for a time, does it make sense to try a newer drug?
That's an interesting question.
Yeah.
Take that one. So one of the interesting phenomenons that happen with, let's say, immunomodulators is as the disease state comes under control, the corneal nerves can recover their morphology and shape and function to sense the quality of the tears, the osmolarity, the response to the environment. And patients may perceive an increase in their symptoms as that corneal nerve recovery happens. In the days where all we had was restasis, this would happen a lot. As the inflammation and the dry eye came under control, there'd be this phase where, doc, I'm feeling more than I was. we know from confocal microscopy studies that that's actually good news, that the corneal nerves are restoring their normal shape and function. So when that happens to you as a patient, definitely visit your doctor again and say, hey, I'm noticing these new things. Do we need to add on therapy, or are my corneal nerves starting to recover? What is this? It could be just a time of year exacerbation, right? So those are definitely things to talk to your doctor about.
Another question in here that's been answered, so I'll read it out loud and maybe there's more answers. So there's so many options to treat ocular surface disease, from drugs to procedures. What tips, tricks, or recommendations do you have for us to engage effectively and efficiently with our doctors to identify the best treatment path? And also, what are your pet peeves so we can avoid them?
Do you want to read what I responded?
Of
And then
course,
I'd love
yeah.
to hear what my colleagues have to say.
So number one, you and your doctor are on the same team. Number two, ask if there are any other innovations, meds, procedures we should consider for my care. Three, what lifestyle changes can I make to help? Ask about the 5 pillars of wellness: nutrition, hydration, sleep hygiene, exercise, and mindfulness. And I'll say this is similar to other answers in the Q&A as well on lifestyle implications.
I wasn't sure how to answer the pet peeve question. Dr. Abbott, Dr. Allen, I think that's a very legitimate question and actually empathetic and kind of that patient to ask.
I think it's important to have a dry eye provider that is compassionate. So patients that are suffering from dry eye, I mean, it's dramatically impacting their overall quality of life. It's on their mind constantly, and it really affects mood. It affects everything that's going on in their lives whenever they're in constant pain. So you really want a doctor that is compassionate. So I mean, um, it, from the doctor's perspective, you know, we need to be compassionate for these patients, and we need to have empathy and understand that the patients are in pain, and not really be bothered when the patients are asking us questions, you know, because if we were in their same situation experiencing as many symptoms as they were, we would be doing the same thing. So I think just find a provider that is compassionate, that listens to you.
Yeah, I think same thing. I think most doctors who really do have interest in dry eye and are pushing themselves to learn more, and whether they're involved with research or just they're interested in figuring out the puzzle because they want to do what's best for their patient. I think if you run into a provider who's dismissive, who's obviously they may be very busy, but if they're not like willing to work with you and try to crack the code or figure it out and help you out, then maybe it's a personality clash or something, and maybe there's just a better provider out there for you. As far as pet peeves, that is a tough one. I think my only thing, and it's not really a pet peeve, it's just I think there's a gap in understanding that, especially because I think every single person who, by the time they get to a quote unquote dry eye specialist, they've probably tried many different artificial tears, right? They've already gone to the store, they've tried a collection of 5 or 6, or maybe they've seen another provider and was given some. But usually it's something you have to stay consistent with. You can't just be, oh, I tried it once or twice and it didn't fix it for me. Well, it's like, okay, we need to be, again, consistent with it. Just like exercise, just like diet, you need to have that consistency to see a potential benefit. Now, over-the-counter artificial tears is a different discussion of its utility, right, with severity of what's going on in the eye. But I think that's an important thing to understand, is that like it's more than just, oh, I tried this random thing one time.
Yeah, I think that's a great point, Joey. So I think you want a provider that's curious about your case, that's trying to solve it, that shows interest, you know, in your case and you as a person. But yeah, what Joey said, if you haven't tried, you know, what your doctor prescribed last time, then sometimes that ends up kind of being a roadblock for us. For instance, like let's say I prescribed a steroid for a patient. I want to know, like, using a steroid, this is quieting inflammation aggressively on your eye, on your ocular surface, and your tear film. if this doesn't improve your symptoms, then maybe inflammation's not a big driver of your symptoms in this case. But then you come back and you haven't used the steroid, then we don't have the answer to that question. We don't know if treating inflammation was helpful or not. So yeah, I agree with what Joey said. Trying the things your doctor prescribed is very helpful for us.
I think one of the things I feel very grateful for today that people can take away from this is, what does it look like to have an engaged and compassionate provider? And you've all three given us some really wonderful illustrations today in what that means, how in relating to each of these topics. Could I ask you each to maybe think of like a final pearl for someone who is considering a dry eye prescription medication or struggling somewhere to navigate that process? What kind of just one extra thing, one piece of hope or guidance for them?
There's always hope. Innovation pipeline is robust. It's steep and deep like a good ski hill. And don't give up. Keep working with your doctor. Keep creating a team environment and working with your doctor, and never ever give up.
Love that. Thank you.
I would say that if you're just starting on a medication, there's many different medications. There's new ones being developed, just as Dr. Periman said. I think just understand there can be some patients who respond super well to one medication. It's not always the first one we try, or the first one that your insurance suggests that we try to use or prioritize. But there's usually many things that need to be done at once, because we've kind of said it several times, like lifestyle plays a big role in a lot of it. Try to minimize what's ever aggravating or making the dry eye worse. And so, no, it's not going to be a quick fix overnight. I don't think it's going to happen. I think I've only had one person where the first medication we tried was instantly, they thought they were cured by it. And I was happy about it, but I was just kind of like, I wonder if that was a placebo effect. But still, it is a journey, but we can all do it together. And it makes us so happy when we see our patients like kind of graduate, right? They're in that process of seeing us every few months until we get them in a better spot. Next thing, we're only seeing them every 3 months, and then every 6 months. And now it's like, I'm only seeing you a few times a year, and they're doing great, right? The surface of their eye looks great. Their vision's great. They're feeling much better. I think we all are praying and hoping for our patients to have that result.
Yeah, so I'll say two things. The first is echoing what Laura said, to not lose hope. And the one way that I try to, encourage this with patients is I have a future considerations line in every single one of my dry eye charts, where I say, this is our plan, but if that doesn't work, here's all the things that I'm considering trying with you next, just to know, like, there's other things that we're thinking about. So, and I always make sure that line is full of options. So know that there's a lot of companies also that are investing a lot of money to try to help you. We're understanding dry better, the pathophysiology better. There's a lot of new things in the pipeline. The second thing is, dry eye oftentimes does not occur in isolation. So sometimes it's not just dry eye. Sometimes there's so many things in your life that's impacting pain perception. I've told patients, I don't think we're going to be able to get your dry eye symptoms better until we improve your sleep. You're sleeping 2 hours a night. You're stressed at your job. You're anxious. You have depression. You have all these things going on. And all this is impacting not only your lacrimal gland secretions and things like that, it's impacting your corneal nerve sensitivity. We know decreased sleep decreases lacrimal gland secretions, but it increases corneal nerve sensitivity. So your eyes become more dry and you feel it more. So sometimes we have to control some of the other things that are impacting dry eye patients' lives too, and be discussing things beyond just the eye that we know can impact the nervous system and therefore impact pain perception related to dry eye.
That is wonderful. Thank you. I think it's time to wrap up today. Just a huge thank you to our panelists, Dr. Abbott, Dr. Allen, Dr. Periman, just for all the knowledge and insights, and I think added reasons to hope and persevere and get creative and engage more with this process and with our doctors, and tips for how to proceed more effectively to navigate those conversations. Just thank you for everything that you brought to the table on this. And thank you to everybody for who joined us on Zoom or on the live stream. And for those of you that joined us on Zoom, you're going to see a survey pop up when you close the meeting. So if you have time, it's just kind of a 2-minute thing. If you don't mind filling it out, that would be great. And Aidan, thank you for running the live stream and Draymond being here to support everybody in the chat and everywhere. And once again, a thank you to Petris for making this possible. Thank you, everybody, and have a good night.